Thank you, Mr. Chairman.
Thank you. Mr. Fitzpatrick, you're recognized.
Thank you, Chairman, and thank you to the ranking member for holding this hearing. Thank you all for being here. With a majority of Americans managing at least one chronic disease, care coordination is essential for better healthcare delivery for Medicare patients. Unfortunately, as has been laid bare here in this hearing, fragmented care delivery has become the new normal, with Medicare beneficiaries seeing 50% more specialists for care compared to just 2 years ago. Fragmented care also has resulted in thousands more in healthcare spending per Medicare patient, which would be entirely preventable with proper coordination efforts for physicians to have time to focus on patient care itself. One specific aspect of care coordination for those struggling with chronic disease I want to discuss is the use of telehealth. Telehealth services have allowed patients to more frequently engage with their healthcare providers for follow-up appointments and improve their treatment adherence. Telehealth has made it easier for specialists and primary care physicians to work together to improve care for patients with complex chronic conditions. This has directly led to fewer hospital readmissions and as well as greater healthcare savings. Dr. Hoben, can you speak to the specific ways that your provider group has utilized telehealth for treating chronic disease, and what were the impacts to these services with the lapse of Medicare payments during the recent government shutdown?
Thank you for the question. So we have leveraged telehealth significantly when it comes to managing chronic disease by access points to the right level of care. So our chronic care managers, who are RNs, that help do a lot of chronic maintenance, monitoring data, like blood pressure values or blood sugar values. Telehealth's connected to our PharmDs, who connect to the advancing of medications or titration of medications to control those conditions and prevent crises and prevent urgent and emergent conditions from happening. So it's been a huge help for the patients that we take care of and we serve in reducing their utilization for higher cost venues like the emergency room in the hospital. Obviously, that was not accessible for some of those Medicare patients during that time, so that was certainly a challenge. And we certainly appreciate that being opened up because it is a large tool that we have to enhance the long-term positive outcomes for the patients that we serve.
Thank you. Dr. Parikh, I want to jump to another barrier to care coordination, and that's the unstable Medicare physician payment system and the successes seen in examples of value-based care. Your group has utilized alternate payment models offered by CMS. Can you speak to the specifics of this model and how you have seen it impact patient outcomes? And beyond the patient outcomes, how has this model impacted overall healthcare costs?
So essentially, in an alternative payment model, instead of getting paid, or in addition to getting paid for the services you're providing, at the end of the year, they look at the outcomes for the population that's attributed to us. So if we have, make a simple number of 100,000 patients, at the end of the, they look at all the conditions that the patient has had and all the utilization from the year before, and they set a specific cost benchmark. At the end of the year, then they look, and did we keep the cost below that expected cost benchmark? But more importantly, they make sure that this wasn't done by withholding, right? We're giving better care to keep costs of care down. And so we are reporting on quality metrics on these patients. So that holds us accountable for this population. For the people coming in with chronic conditions, we're focusing on primary prevention, right? So they don't get a new chronic condition screening, education, weight loss. Secondary prevention, that diabetes doesn't get worse and cause blindness, cause vascular disease, cause heart attacks. And then tertiary prevention, those people who already have the complications, that they don't get worse if they've got retinopathy, that we treat it early and prevent them from going blind. So that's one part of it. The second part of it is that now we're accountable for patients who are not coming in, right? So now we have registries and we use analytics to make sure that the patients that we are accountable for that have diabetes but just haven't come in, that we reach out to them, we bring them in, if they can't come in, use telemedicine to make sure that they get the care that they need. And what the outcomes from this show, as I've said earlier, is that when you use an accountable care organization, those patients particularly MSSP, Medicare Shared Savings, and ACO REACH have shown that they have higher screening rates, they have better chronic condition management, they have lower emergency room visits, they have lower hospitalizations, and then with all of that, lower cost of care. Medicare saves money, and then we get some of that shared savings to, again, reinvest in care coordination.
Thank you. I yield back, Mr.